Good evening to one and all present here. Before I start my presentation, I would like to thank the IAB team, Dr. Lima Madam, Dr. Ramakrishnan Sir, and Dr. Sriram Sir for giving us this opportunity to present in this forum.
But Ramesh, mute for,
Yes, I will mute. Yes.
Yeah, please proceed. Yeah.
A 17 years old adolescent male, firstborn to non-consanguineous parents, who's residing in Coimbatore, whose informant is both mother and father, their reliability is good. He was brought to us with complaints of increased uncontrollable movements of both hands and legs, swelling of both legs for 1 week, reduced urinary frequency for 1 week, and difficulty in breathing after walking for few steps for 3 days. At 9 years of age, parents noted him sitting very close to the TV and increasing the volume of TV. He was found to have bilateral hearing issues and was provided with hearing aid. Hearing difficulty further progressed. At 10 years of age, he was unable to hear with hearing aid and he stopped using the hearing aid. And hence, he stopped going to school because of hearing loss. At 10 years of age, parents noticed that his hands are shaking whenever he tried to reach an object. It was gradually progressive. Initially, it was in the right hand and then followed by the left hand. His regular activities like combing hair, brushing, buttoning shirt, and self-feeding got affected. He has been fed by parents since then, hence not able to assess spillage of food while eating. At 11 years of age, he developed head nodding, followed by swaying of body to sides while getting up from bed. At 12 years of age, he had unsteadiness while standing and walks with legs apart. Progressively, he was unable to stand and walk without support. His walking distance got reduced. His speech got affected from 12 years of age. Length of sentences reduced, and he started speaking only single words slowly with reduced fluency. At present, he's ambulating with support. He's not having any issues regarding his sleep-wake timings, food habits, emotional disturbance, and remembering his routine. He did not have any behavioral disturbance. However, mother has concerns about his memory as he doesn't remember which school he studied. Mother says he can identify food with smell. She did not have any concern regarding his vision. She did not notice any abnormal eye movements. There was no difficulty in identifying different objects, colors, or in looking around. He is able to chew his food and swallows without difficulty. Mother did not notice any facial asymmetry while laughing and crying. He closes his eyes while sleeping. He is able to turn his neck side to side. Mother did not notice any stiffening or floppiness. He winces on receiving Venflons or IM injections. His bowel and bladder habits are normal. No history of excessive sweating. There was no history of fever with headache, intractable vomiting, or exanthematous fever. No history of trauma. There was no history of recurrent respiratory tract infection. There was no history of abnormal increase in head size. There was no history of abnormal distension or jaundice. There was no history of abnormal pigmentation of skin or hair. He did not receive any recent vaccination or chronic. There has not been any chronic drug intake, and there has not been any abnormal odor of urine. Now, he is admitted with difficulty in breathing, bilateral leg swelling, and decreased urine output. He is being treated with IV medications, and he is now symptomatically better. Past history, he had seizures.
Wait, my dear. Discuss the history of present illness and the complaints. What do you mean by you said some uncontrollable movements of the hands and legs? What do you mean by that? What is your inference? What is that? Whether it is an involuntary movement or clumsiness of movements you are going to say?
Ma'am,
what about this? What is this uncontrollable movements, my dear?
Yes, ma'am. Uncontrollable movements of both hands and legs. It could be either tremors, ma'am, or it could be seizures, or it could be even dystonia, ma'am. Dystonia is a possibility, ma'am.
No, my dear. Seizures are all episodic. Is it not intermittent? They cannot be they cannot be continuous. If you are telling that from the complaints, what the mother said in her terms, tell me.
In her terms, like Shakiness of hands, ma'am. It is what she said. Shakiness of
Kai
hands.
nadungudu. That's
Kai
what she
nadungudu.
said. Kai nadungudu.
Yes, ma'am.
You should have asked immediately exactly கை நடுங்குதுன்னா என்ன எப்ப நடுங்குது சும்மா இருக்கும்போதே நடுங்குதா ஆர் ஏதாவது பொருளை எடுக்கும்போது நடுங்குதா சும்மா இருக்கும்போதே நடுங்குதுன்னா my dear it could have been a rest tremor, is it not? And then பாஸ்டர்ல ஏதாவது கையை தூக்கும் போது நடுங்குதா ஆர் ஏதாவது பொருளை எடுக்கும் போது நடுங்குதா? See, later on you have said about certain cerebellar symptoms like your head nodding and then clumsiness of movements in the form of go to the next slide. Next. Here you have said no, previous slide. Yes, the parents have noticed that his hands are shaking whenever he wants to, he has to reach an object. Okay, what do you mean by that?
Ma'am, it is a kind, it is a kind.
It is nothing but an intentional tremor. Okay, whenever they are approaching a target, the child is having shakiness, shaking hands. Okay, so it is nothing but an intention tremor.
Yes, ma'am.
And then it is gradually progressive. Initially, she has found out in her right hand, found out in her son's right hand, followed by the left hand.
Yes.
And then regular activities like combing hair, brushing, buttoning, and all got affected. Means what do you mean by that? It is nothing but the clumsiness of the movements. Okay. Yes, whenever for that, what you have to in fact ask is whether he has any difficulty in mixing the food. Suppose they have any difficulty in the mixing the food or making mixing the food, means that could be a weakness. Any history of difficulty in gripping or holding a tumbler or holding an object, that again could be a distal weakness in her hands. When they are under, then the next thing what you have to ask is whether he has any difficulty in taking the food to the mouth, whether the child is spilling the food, or whether the child is has any difficulty in taking or drinking the liquids. And whenever he has, they tell us a history of spilling of the liquid while feeding, that it means, or whenever the child takes the food to the mouth and he or she smears the food over the face or spilling of the food, that means clumsiness of movements. Okay, so that means it is an cerebellar system involvement, that or it can be equated to appendicular ataxia. Okay, it could be a dysmetria, it could be intention tremor. So necessarily whether it is an intention tremor or whether it is a clumsiness of movements pertaining to the cerebellar system involvement, or whether it is a involuntary movements like a chorea or a tremor, these two things we have to clean from the history wise itself, we have to distinguish. Okay, if it is present in the at rest itself, we do not have in children rest tremor and all. It is all in adults. Pill rolling movements you might have seen in a patient with a Parkinsonism. Okay, rest tremors are not that much not at all common in children. So in children, what and all what tremor we can have is only an postural tremor. Whenever they raise the hand above or in the front, then they can have tremor. And another involuntary movement, which is chorea, you might be very well know of. About chorea, you must be able to tell us what is chorea, my dear. Define chorea.
It is due to basal ganglia involvement, ma'am.
Define.
Involuntary movements involving abnormal proximal movement.
Whether it is a purposeful or a purposeless.
Semi-purposeful involuntary movement, ma'am.
Good. Quasi-purposive, semi-purposive involuntary movement, whether it involves the proximal or the distal, the joints. It involves the dancing character, and it spreads to the distal also, which disappears during sleep. This is what you had to tell us for chorea. You said something about dystonia. What is dystonia?
It is painful. Dystonia is painful movements, ma'am. Painful.
Maybe painful or painless also. Not necessarily painful. That is abnormal posturing of the limbs. Okay, dystonia is abnormal posturing of the limbs, which can be fixed also sometimes. So with an axial rotation, if the limbs are like that, so posturing of the limbs only, you have to tell us that it could be a dystonia. So your first complaint is uncontrollable movements of hands and legs. That has to be clarified. So you have to, from the history, they will be telling something. So we have to ask them, put forward certain questions to distinguish between whether it is a movement disorder or whether it is ataxia. That is number one. Okay. Yes. And then you have very nicely said that the child has difficulty. So in combing the hair, brushing, buttoning, self-feeding got affected. And he has been fed by the parents, hence not able to assess the spillage of food, you have said. But initially, he would have been drinking by himself. He would have been feeding by himself. So at that point of time, whether there was any spilling of the food, you have to ask. Okay.
Yes,
later on, it would have been so much that the parents, he would have spilled so much food. So the parents would have started feeding him.
Okay.
Okay. Next history, you follow it up at 11 years of age.
At 11 years of age, he developed head nodding, ma'am, followed by swaying of body to side to side.
Again, head nodding, whether it is in the vertical direction or in the horizontal direction, my dear.
When he lifts his head up, vertical direction, ma'am. When he lifts
So
his head
vertical
up,
direction is
titubation.
vertically. Yes, very good. So vertical direction, it is for your level. In the vertical direction, somebody nods the head, it is the titubation. If it is like this in the horizontal direction or yes, it is titubation. No, it is a head tremor. Okay. So he has developed a titubation and then followed by swaying of body to sides while getting up from bed. What do you mean by that?
It's truncal
Whether
ataxia.
he was able to sit with very good. Truncal ataxia. So you can add one more sentence saying that did he have any difficulty in sitting on his own, or whether he swayed to the back, to the side like that also. Whether he was able to sit by himself without support.
He was not.
Initially, it would have been over the years or over the months, he would have lost that also. Okay. Yes. Next.
At 12 years of age, he had unsteadiness while standing and walks with legs apart, ma'am. Progressively, he was unable to stand and walk without support.
What do you mean by difficulty or unsteadiness while standing itself?
It is due to weakness, ma'am. Weakness, ataxia.
So far, you have not told anything about the weakness. In fact, I have to ask you that also. This is due to ataxia itself.
Ataxia.
So when the child or the patient is not able to sit without swaying, then it is the truncal ataxia. When the patient is not able to stand without any swaying, then it is called a stance ataxia. Okay, gait is while walking. Okay. So he had difficulty, unsteadiness while walking also. He was walking with the legs apart. So you mean you are meaning a broad-based gait? Is it so?
Yes, ma'am.
Okay.
Broad-based gait.
So there was a gait ataxia also. In the gait ataxia, you have to tell us 2 more points. Whether there was any history of swaying to either side or any particular side.
It's right. It was swaying to either side, ma'am.
On either side.
No, not particular side, ma'am.
Okay. Not to the right or to the left.
No, ma'am. No, ma'am.
Because initially you said clumsiness of movements appeared in the right hand first. Okay. But when he developed the gait ataxia, he was not swaying to any particular side. Is it so, my dear?
Yes, ma'am.
Okay. So it was the gait ataxia. Okay. Yes, so what is the importance of asking this question? What is there if he sways, let him sway to the right or let him sway to the left?
In cerebellar lesions, once they get up from bed or while they are standing, they will sway to the other side.
No, my dear. In cerebellar lesion for pyramidal tract,
they sway to the side of the
we are localizing. Okay, and for cerebellar lesion, it is due to double crossing. It is on the same side.
Same.
Okay. So suppose the patient is swaying to the right side, it means right cerebellar hemisphere is involved. Okay. For localization. Whether it is only, and what do you mean by this truncal ataxia? Where do you want to localize for truncal ataxia, for stance ataxia and all?
Vermis of cerebellum, because that is involved in.
It is the midline. It is the midline involvement. So midline cerebellar structure, namely the vermis is involved. Suppose there is a particular, like your clumsiness of movements only in the upper limb or only in the left, right side or left side. Then you can say it is due to that side cerebellar hemispherical involvement. Okay. Similarly, similar to your gait ataxia with swaying to one side, one particular side. That denotes that side cerebellar hemisphere is involved. Okay. So here you have involvement of, you have history suggestive of both midline structures as well as the cerebellar hemispherical involvement. History pertaining to cerebellar hemispherical involvement. Okay. Right. Next question. Next line.
His speech got affected from 12 years of age. length of sentences reduced, and he started speaking only single words slowly with reduced fluency.
Okay, what do you mean by this speech affected?
Ma'am, actually, scanning type of dysarthria, ma'am.
What are the different types of speech involvement you can have in cerebellar lesions?
Scanning and staccato speech, ma'am. Scanning
That
speech.
can be slurring speech, scanning speech, and staccato. What do you mean by slurring? If you pronounce the word, if the end syllables are not heard clearly, then you call a slurred speech. You take any word, take say speech, sh, that is the last syllable, that is ch, you are not able to hear at all, then it is a slurring. What is scanning?
They will scanning type of speech. They will say the same word, but in a
Each
very
syllable, no, my dear. Each syllable is separated. Say like that, or pallavan, like that. Each syllable is separated. Okay, with gaps. Then it is called a scanning speech. What is called a staccato?
With a bold, with a.
It has something to do with the pitch of the speech. So where our intonation, where you need not give significance, you will be giving more significance or more intonation. That is called staccato speech. Suppose somebody is telling, see, pallavan. So one is not heard, it is slurring. Pallavan, it is scanning. Pallavan, where you need not stress at all. Suppose somebody is speaking like that, so where you need not stress, or where you need not increase that, when the tone of the speech is affected, you call it as a staccato speech. Okay, so clearly you have to mention from the history whether there was a slurring, or you can say the words are incomprehensible, like that you can say. Okay, right. Now next slide.
At present, he is ambulating with.
So so far you have what you have told us about your clumsiness of movements, then about truncal ataxia, and about gait ataxia, and about stance ataxia. So we are able to get information about whether it is the cerebellum. What do you think about this? Whether there is a pancerebellar involvement, or only the midline cerebellum, that is vermis, is involved, or only the
pancerebellar involvement.
Why do you say it is a pancerebellar?
Because
both the vermis as well as both the hemispheres are involved, you call it as a pancerebellar involvement. Okay, and where do you want to place that this one, the speech abnormality?
Paravermis.
Good. So in the left cerebellar hemisphere, in the paravermial region, you can localize the speech abnormalities. So the next important thing in the history itself is, whenever you find or whenever you have a history of unsteadiness while walking, what are the causes for ataxia, or what are the causes for difficulty in maintaining the balance, my dear? What are all the other causes?
Ear involvement, ma'am. Labyrinthine.
Don't say it. Be specific, my dear.
Ma'am, causes for ataxia we can classify into acute causes, ma'am, or inherited.
No, not that I am asking. Unsteadiness. What are the problems? Whenever somebody is telling, I am not able to maintain my balance, I am unsteady.
Yes, ma'am.
What are all the causes that can cause unsteadiness?
Vertigo, ma'am. Weakness.
No, vestibular involvement. Next.
Sensory.
Cerebellar involvement, or
sensory system.
Yes,
involvement.
You can have a posterior column involvement. These are, whenever any one of these structures are involved, you can have an imbalance. Okay. Now tell me, how will you distinguish between how will you rule out or exclude a vestibular involvement?
It's associated with vertigo, tinnitus, ma'am.
Very good. It is associated with vertigo and tinnitus, number 1. Number 2. Nystagmus will be there, I accept. During that episode, okay, there can be vomiting also. Yes, I do accept all those things.
Sleep.
No. Somebody is unsteady due to vestibular lesions. They will not have anything in the upper limb. So you can't have an appendicular ataxia at all. Number 3, there won't be any dysarthria. That is, speech is not involved. Okay. So these are the 3 things which can help us to distinguish between a unsteadiness or to exclude an unsteadiness of vestibular etiology. Now we are left out with the cerebellum, either cerebellum or posterior column involvement. Now tell me how to distinguish these two from the history.
Sensory ataxia, when
Romberg sign is a sign, my dear. After examination only we can say.
Like when they go inside the dark, like eyes are closed, like they will not be able to maintain.
History. What will you ask in the history?
While washing face.
Any unsteadiness which worsens during the evenings or during darkness is, you are telling only, but you have to rephrase it. That's all. Okay. Any unsteadiness which increases during darkness is due to posterior column involvement, or it is a sensory ataxia, not a cerebellar ataxia. Number 1. Or other, to put it in the other way, when the visual cues are taken away, if somebody feels the unsteadiness is worsening when the visual cues are taken away, that is sensory ataxia. Okay. And again, speech is not involved. These 2 are the distinguishing features between a cerebellar ataxia and the sensory ataxia due to your large fiber involvement or a posterior column involvement. Okay. There is a sign which can help us to distinguish this. What is that? What is called a wash basin sign?
While washing face, they swaying. While washing face, they might have difficulty.
Nobody can wash their face with their eyes open. Okay. When you wash your face, you have to necessarily close your eyes. So once the visual cues are taken away, they will feel very unsteady and they will fall down. So this is pointed towards a sensory ataxia. Okay. So whenever you come across a history of unsteadiness while walking, immediately you have to ask these questions, so that at level 1 itself, or at the step 1 itself, we have to exclude vestibular etiology and whether it is a sensory ataxia or not. In some of the cases, there can be both can be present, like cerebellum plus posterior column. In such situations, there will be unsteadiness while walking, and it will be increasing or worsening during darkness as well. Okay. So this is number 1. And then other things and all you have told, and you have to tell us whether there is a weakness or not. Now, one part of the neuraxis is involved, that is the cerebellar system. We do agree. And then whether the pyramidal fibers are involved, whether there is extrapyramidal involvement, other things also you have to tell us. You have in detail, you have told us about the cranial nerves. I do appreciate your history taking is very good. It is of your expressions are very good. Now tell me whether there was any weakness of limbs.
Ma'am,
what you have
ma'am, we could not say whether it was weakness because of the tremors. Did the patient have difficulty in feeding, or was it due to the proximal weakness?
No, you have to ask the parent whether he has difficulty in getting up from sitting position, whether he has any difficulty in holding the slippers. For the upper limbs, whether he has any difficulty in raising his upper limbs or hands above the shoulders, whether he has any difficulty in holding objects, whether he has any difficulty in lifting weights. Okay. All these things will tell you whether there is any history of weakness of the limbs. You have nicely put forward that there was no history of stiffness or flailness of the limbs. That and all, I appreciate you. And there was no history of sensory disturbances. For that, you have rephrased in such a manner it was pleasant in history taken from a child. That and all, I appreciate you, my dear. The next important thing is there was a history of hard of hearing. Now explain to me about those things. Whether it is a conductive deafness or a sensory neural deafness.
Because
what was whether ataxia came first or the deafness, the hard of hearing came first?
Ma'am, hard of hearing was the first symptom, ma'am, which started, and it was because the mother said he had worn a hearing aid. It is highly likely it is a sensory neural hearing loss, ma'am, and which did not improve with. It was progressive and which did not improve with hearing aid, ma'am.
That is, for that you have to ask whether there was any history of ear discharge, whether there was any history of trauma, such things. Okay. So something to do with the CSOM and all, you can say it could have been a conductive deafness. That's what we expect from you. Okay. So there was a hearing loss in both the ears. That is an important cranial nerve history. Okay. All the other cranial nerves are intact from the history, whereas he has a bilateral hearing loss, which was also progressive, is it not?
Yes, ma'am.
Okay. Anything else in the history? No, don't go to the etiological history much to, first of all, we have to finish the history of present illness.
He was unable to get it from...
Ramakrishnan, good evening. Dr. Ramakrishnan.
Good evening, madam. Good evening,
good evening, Pa. You have heard about their history and all.
Yes, madam. I have heard about the history. I have heard the discussion also.
Please
madam.
add some. Please add. So we
madam,
have so far discussed about the cerebellar symptoms and.
Yes, madam. I heard, madam. I was there only, madam. Only thing I would want to ask them is, in the history part, he had weakness. He had difficulty in lifting the neck and he had difficulty in turning over in bed. So I think probably they might have forgotten things.
Okay. Okay.
Apart from that, you have covered everything, madam.
Okay. Now the next most important thing is, my dear, about the onset and the course of the illness. Okay. That only will see the history of present illness has two important parts. First one is we have to find out which are all the structures involved or which part of the neuraxis is involved. Then the second part will give us a clue about the etiology. So two questions, that is the onset and the course of the illness, is again important to say whether it is an acute onset or whether it is an intermittent one or a chronic. Suppose if it is an insidious onset, then whether it is a progressive or a non-progressive. Okay.
It's an insidious in onset and it is progressive in nature.
Progressive, very good. So it is of insidious onset and a progressive in nature. Okay. Then going to the etiological history. Next. And you have said something about his poor scholastic performance or something, is it not?
Yes, he stopped going to school after he had hearing loss, ma'am.
Because
once his hearing worsened, he stopped going to school, ma'am.
Okay. But otherwise, he
studied till 4th standard, ma'am.
How does he communicate with his parents and all, with his siblings?
Through sign, he understands the parents through sign language, ma'am, and lip reading, ma'am.
And lip reading. Okay.
And lip reading.
Then how come this mother found out that he has memory disturbances?
Ma'am, when we are the parents asked them like through sign language. I mean, the mother, he doesn't remember the past memory, ma'am. Like the father asked in front of us, like whether it's his friend's name, which school did he go. They asked all that, ma'am, and he told like Terila. He just Terila. He just told like that, ma'am. When they asked him which school he studied or not.
Okay, proceed. Go to the etiological history. So you want to say some amount of cognition is also involved.
Affected, yes, ma'am.
Okay. Etiological history. So now you have come to a conclusion that it was a chronic disease. It is a chronic disease.
Yes.
With a duration of nearly 3 years. Is it not? Onset is at 9 years. Now, no, more than that. 8 years.
8 years, ma'am.
8
yes,
years.
8 years.
So 8 years duration. So it's a chronic illness, and it seems to be, and it is a progressive. Is it so?
Yes, ma'am.
Yes. So chronic progressive. What are all the possibilities about the etiology?
Ma'am, it could be either it could be to neurodegenerative or a neurometabolic cause, ma'am.
So chronic progressive, we have only two etiologies, my dear. One is, as you have said, a degenerative condition, or it could be a tumor also. Only thing is here the duration is much prolonged, nearly 8 years. Hence, a tumor cannot be, if it is a very slow growing tumor like that, say suppose months to years, then we can accept not for 8 years. But however, whenever we say it is a chronic progressive, always we have to think about SOL also as a possibility. Hence, you have to ask.
Fever with headache or features of raised ICT.
Raised ICT. Which type of which tumors are common in children? Supratentorial or infratentorial?
Supratentorial.
But in the commonly in children, we have infratentorial or posterior fossa tumors are common. Brainstem glioma or your cerebellar midline tumor, medulloblastoma, or cerebellar astrocytoma. Hence, it is necessary that we have to ask for increased ICP symptoms. That's why you have put, you have mentioned about why fever, my dear, fever with headache. What is the importance of fever for such a?
Any meningoencephalitis could, in a previous past history, TB meningitis.
So in a post meningitis sequelae, you can have ataxia as a post meningitis sequelae. Not that much common. Post meningitis sequelae, post encephalitis sequelae, focal deficit. I do accept paraparesis or quadriparesis, cranial nerve deficits, cognitive disturbances. All those things are common. Not ataxia. No.
Epstein-Barr virus infections or varicella can have attack. Yeah, but it is an acute.
How many cases? That is for acute.
Acute.
That is for acute ataxia. Now we have come to a conclusion that it is a chronic progressive ataxia. Okay.
Yes,
so pertaining to our case only, we have to we have to mention the etiological history. If you say headache, vomiting, then I accept. Okay. You want to rule out whatever it is, whatever may be the duration of the illness, you want to rule out a tumor. Yes, I accept. Okay. Next.
No history of recurrent respiratory tract infection, ma'am.
What for you are asking?
Ataxia telangiectasia, they can have recurrent infection.
Next. Good. Next.
Increase in head size, ma'am.
What for?
In neurodegenerative cases, in Alexander's canavins, but they can have a large head, ma'am. Abnormal increase in head size, ma'am.
Presenting as ataxia?
Will they present with ataxia, Monish? Generally, they don't present with ataxia, no?
Yeah. Increase in head size. Whatever you have said, increase in head size, degenerative disorders, the leukoid or white matter degenerative disorders associated with the macrocephaly.
Alexander disease and canavins, ma'am.
Good. Gray matter. Mucopolysaccharidosis, Tay-Sachs disease. Okay. But those conditions may not present with ataxia. There are some other conditions like megalencephaly, leukoencephalopathy with subcortical cysts or Vandernapp's disease. Such conditions can have ataxia, but those are all not for our level of IDUPA. So leave it. Or you can say that it could be an hydrocephalus itself. Okay, arrested hydrocephalus or something, now only increasing head size like that, but it is not common. So take away that line. Next, recurrent respiratory tract infection. Yes, necessarily you have to mention. Next.
Abnormal distension or jaundice, ma'am. Wilson
presenting as an ataxia. What are all the different presentation, different neurological manifestations, and your neuro Wilson will present to you.
Cognitive impairment, ma'am.
Neuropsychiatric. Okay.
Neuropsychiatric, yes, ma'am. Basal ganglia involvement. Neuropsychiatric involvement, basal ganglia involvement, ma'am. Seizures.
Clinical presentation. Seizures are very, very rare. To your level, it will not occur.
Chorea, ma'am.
Dystonia is the commonest presentation. They will present you with the dystonia. Second one is they can have choreic presentation, but and all again that and all is little rare only. pseudocerebellar with the pattern, and even proximal weakness pattern also is there. But the predominant neurological manifestation is dystonia. So that also is, which should be taken away. Next. Abnormal pigmentation of the skin or hair. What for you have asked? What was in your mind?
Or adrenoleukodystrophy, ma'am. Menki kenki is also, ma'am, for hair. And vitamin B12 deficiency, ma'am.
Ataxia. Adrenoleukodystrophy presenting as ataxia. No.
All these things are very rare now.
They will have gait difficulty, progressive visual difficulty, and gait difficulty, not as ataxia. Okay. Another one, what did you mention? Menki kinki. Menki kinki and all not in this age group. Okay. Developmental delay, hypotonia, seizures, and alopecia, seborrheic dermatitis, something like that in infancy. So again, it has to be taken away. Next.
Recent vaccination or chronic drug intake, ma'am.
No, that and all for acute ataxia. Chronic drug intake, which drug you are mentioning?
Phenytoin.
Good. Phenytoin in the acute period itself, acute ataxia it can cause, and even in the pharmacological doses, it can cause ataxia, acute ataxia. In on examination, you will have nystagmus and then unsteadiness or truncal ataxia, everything. And nystagmus is the earliest sign of phenytoin toxicity. Even in pharmacological doses, you can have ataxia. You might have given only 5 milligram per kg per day in 2 divided doses in your for a child after admission in your ward. But the next day morning, when you examine the child will be very much wobbly, very much ataxic. Why it is so? Why this phenytoin is causing ataxia, even when it is in the pharmacological dose? You might have given only 5 milligram.
Increased uptake. Crosses.
Phenytoin follows which order kinetics, my dear?
Pharmacodynamics.
Pharmacodynamics.
Both zero and first order.
That's why there is a very narrow interval between the maximum pharmacological doses and the maximum tolerable dose and the toxic dose. That's why we have to be very careful. As you have said, chronic phenytoin intake also can cause cerebellar atrophy, and that will take years, my dear, not for like this in adults. Okay, so I will not expect you to say all these things. Why did you ask abnormal odor of urine?
For maple syrup, for maple syrup.
Again, that will be not be a chronic
age.
progressive ataxia. It will be an intermittent ataxia. All these IEMs or your pyruvate carboxylase, pyruvate dehydrogenase, your MSUD, all those things will cause intermittent ataxias. So again, that has to be taken off. One more history I would like to expect from your mouth in a chronic progressive ataxia. Now enumerate the conditions that will come under degenerative ataxias or under the rubric of chronic progressive ataxias.
Ataxia, vitamin E deficiency, ma'am.
First one is Friedreich ataxia. Okay.
Friedreich's ataxia.
The next one is ATM.
Vitamin E.
Good.
Vitamin E deficiency induced ataxia, ma'am.
Dependent ataxias. Another one.
Cerebrotendinous.
CTX. Okay. Anything else? Even before all these things? A beta lipoproteinemia. Okay. A beta lipoproteinemia. So in A beta lipoproteinemia, you will have malabsorption symptoms. So you have to ask any history of recurrent diarrhea. These two histories are very, very important. So any chronic progressive ataxia, I would like to expect 3 questions, 3 things in the etiological history. One is about ICP symptoms. Second one is recurrent respiratory tract infection because you are thinking in terms of AT. And number 3 is recurrent diarrhea because you are thinking in terms of A beta lipoproteinemia or hypobeta lipoproteinemia. Okay, right. And Sarah has asked, and another thing also in the history, in the complaints, you have added something like decreased urine output, And another one, what is another thing? Breathlessness while
Swelling of
walking and all.
swelling of foot and decrease
Yeah.
kinds of cardiac involvement with dyspnea.
Is it renal or is it cardiac?
It is cardiac, ma'am, because dependent edema by both legs.
You haven't told us about anything about facial puffiness and all in the history. Is it not? And for how long these symptoms are there? Cardiac symptoms are there?
1 week, ma'am.
Okay. Okay. Next slide. Okay. Okay. So anything else, Ramakrishnan? Please. Ramakrishnan, anything to be added in the present history?
Nothing much, madam. Nothing much, madam. I think we have covered everything.
Okay, pa. Proceed, my dear.
Past history.
Take over, Ramakrishnan.
Okay, madam.
Proceed, my dear.
Past history, he had seizures at the age of 3 years in the form of vacant stare, lasting for 20 seconds with no post-ictal confusion. He was treated with oral valparin and was discontinued after 1 year.
Okay. But did he have any seizures after that, Maunesh?
No further seizures after this, sir.
Okay. Only one
episode of
okay.
seizure at 3 years, sir.
Okay.
Was it associated with fever?
No, ma'am, not associated with fever, ma'am. Just vacant stare for 20 seconds.
So it was an unprovoked seizure of only very few seconds.
Yes, ma'am.
Okay.
Unprovoked seizure, ma'am.
Okay. Single episode only, is it not?
Single episode, ma'am.
Okay, fine. Proceed.
Like natural conception registered in a private hospital. Mother had regular visits. She took regular iron and folic acid supplements. Antenatal history was uneven full. Birth history, full term cesarean. The birth weight was 3.25 kg and the baby was discharged on day 3. Postnatal history was uneven full. He attained milestones at appropriate age. He was going to school till 10 years of age with average scholastic performance. He is immunized up to date as per national immunization schedule. Before pre-illness, he received 1,880 calories against an expected of 2,400 kilocalories and 32 gram of protein against 40 gram, with gap of 520 kilocalories and 8 gram protein. He takes adequate green leafy vegetables and calcium-containing foods. Family history: she is non-consanguineous parents. First gestation, there was spontaneous abortion at 8 weeks. He has a girl sibling, who is currently 12 years of age, had similar complaints of hearing loss at the age of 9 years, followed by involuntary movements and difficulty in walking. She is currently walking with support. Her speech is also slow, now able to speak few words clearly. There is no history of hearing loss or blindness or developmental delay or cardiac illness or early onset diabetes or unexplained death among family members. Socioeconomic history: father is an engineer, mother is a homemaker, earning 50,000 per month, living in their own house, belongs to upper middle class as per modified Kusami scheme.
Okay, please summarize, Maunesh.
This 17 years old adolescent boy, first born to non-consanguineous parents, who was developmentally normal till 9 years of age, developed gradual loss of hearing, followed by involuntary movements of hands, making him unable to hold his neck straight, comb hair, button his shirt, and self-feed. He has unsteadiness and swaying while getting up from bed. Speech was slow with single influent words. He has history of seizures and loss of past memory. History of similar complaints in the sibling. Now developed breathlessness with bilateral leg swelling and decreased urine output, which improved with treatment.
Okay, what are all the structures involved? I think madam have discussed. Anyway, for repetition, you have to tell at the end of summary what
Yes,
are all the structures in.
Yes, sir. Since there is gradual loss of hearing, there's 8 cranial nerve involvement, sir.
Bilateral
8 cranial nerve involvement, sir. Truncal ataxia, he has dysarthria, and all this points towards cerebellar involvement, sir.
Okay.
As there
Both
is
cerebellar hemisphere involvement.
Both cerebellar hemisphere involvement, sir. Since there is
Go
loss
ahead.
of past memory and there is history of seizures, there is also probability of cortical involvement, sir.
But only one episode of seizures, is it not? Only one episode of seizures. His memory, I don't know, madam. It has to be. It's not very. What shall I say? Core enough or strong enough to suspect cortical involvement. Because you said he had difficulty in remembering his friend's name, school name. That's all. So we have to take it with a pinch of salt only. That is not very convincing. Diffuse cortical involvement.
Okay. Yes, breathlessness, bilateral leg swelling, and which points towards cardiac involvement, sir.
Okay.
And the etiology, because it follows a chronic progressive course, it's either neurodegenerative or neurometabolic.
Okay, neurometabolic. What are all the neurometabolic disorders that might present in such a way? I don't think so. Anyway, you please elaborate.
Okay. So shall I proceed with the examination?
Thakur, you have
One second, madam.
one more thing. You have a younger sibling is also affected with a similar type of illness. Okay,
Yes, yes,
that means it is an inherited disorder.
Yeah.
Okay, so of course, all the neurodegenerative disorders are now called neurometabolic disorders because after the diagnosis or after this identification of enzymes, etc. But this is a chronic progressive ataxia, so it is a degenerative disorder and it is an inherited disorder. It's not an acquired disorder. Another family member is also affected, and from the though it is non-consanguineous only, but in the another sib is affected. So we have to find out whether the parents are carriers, and this goes for an recessive pattern like that. Because it's not present in the any other family member in the extended family are affected?
No, ma'am. No, ma'am.
No. So it is an inherited disorder and it is an degenerative disorder. Okay,
Yes,
that much we are able to conclude from the history. Oh yes,
Which type of
and
disorder?
if you are mentioning the metabolic disorders, most of the metabolic errors like your amino acidopathies, organic acidemias, they can have, and you have they will all have an intermittent ataxia, not as a progressive ataxia. Intermittent ataxia. Whenever they have an acute metabolic insult, they will present ataxia. They will be presenting with the cerebellar symptoms. Then once the stress is relieved, then there may be some improvement. They may not be left out with there may be some residual involvement, but it can't be a progressive ataxia. Okay, since there is a progression, it is only a degenerative etiology.
Since both the siblings has got affected, probably that should give you a clue to evaluate for progressive attacks. As for example, what mode of inheritance this could be. That might help you out. What could be the mode of inheritance?
It could be mitochondrial or autosomal recessive.
So you should think of those conditions when you are going to discuss about the management plan.
Yes.
Yes, my dear, proceed to the clinical picture, clinical that is clinical examination.
General examination is conscious, oriented, lying in a semi-recumbent position comfortably, the right side neckline present, bilateral pitting pedal edema, there's no pallor or icterus or cyanosis or clubbing or lymphadenopathy. Vital signs: pulse rate 74 per minute, regular rhythm, normal volume and character, no radiofemoral delay, peripheral pulses felt in all 4 limbs. Respiratory rate 18 per minute, thoraco-abdominal. BP 120 by 70 millimeters of mercury, measured in right upper limb in sitting posture. Temperature is 98.4 degree Fahrenheit. Saturation is 99%. In room. Head to foot examination. Head appears normal in shape and size. No dysmorphic facies. Hair is normal. Eyes, no corneal opacities or cataract or telangiectasia. Limbs, there is no contractures. Back, there is no bed sores. Skin, no neurocutaneous markers, no hyperpigmentation. Anthropometry, weight is 47 kgs, between 10 to 25th centiles. Height 170 centimeters, between 25th to 50th centile. BMI is 16 between 5th to 10th centile.
Maunis, go back in one slide. Okay. Neurocutaneous markers, what are the things you will expect in a child with chronic progressive ataxia? What are the neurocutaneous syndromes, or what are the things you are looking for it?
Tuberous sclerosis.
Tuberous sclerosis, I don't think so. It will not present with chronic progressive ataxia, no? They can have epilepsy, intellectual impairment, autistic features like that. They will not present with chronic progressive ataxia. You yourself told, no? Xanthomas, one we can look for.
Xanthilas.
And telangiectasia.
Xanthoma will be present. There will be. Ataxia telangiectasia.
Okay, go ahead.
Where will you look for telangiectasia? Where and all will you look for telangiectasia?
Ear, eyes.
Eyes na where? Cornea, conjunctiva.
Conjunctiva.
In the bulbar conjunctiva, on the temporal
Bulbar
side.
conjunctiva. In the bulbar conjunctiva.
Nasal side, temporal side.
Temporal side.
It
Yes.
will be like a corkscrew shaped. It should have a corkscrew shaped, because just a congestion or a congestion, you can sites where you should look for. You can look for telangiectasia.
Kidna, ma'am.
Good.
Yes.
The palate also. Okay. So telangiectasia is most important one which we have to look at, because if there is a telangiectasia, then your diagnosis is just like that. It is AT. That's all. Ataxia telangiectasia. Very good. Any other thing? Why did you look for cataract? What for?
Wilson's disease.
My dear, Wilson, child is developing cataract is very, 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 very late stages. It's called a sunflower cataract. Any cerebellar pathology, any syndrome associated with the cataract? Okay. It can occur with the Marinesco-Sjogren syndrome. Okay. Just go and see Marinesco-Sjogren syndrome. And again, you are telling about mitochondrial, no? Yes. You are telling that it could be a mitochondrial pathology also, because of the other sibling is also affected. Yes. So cataract can occur with mitochondrial etiology. Why corneal opacity?
Malabsorption.
Okay. Any other thing we have to look for? Mucopolysaccharidosis will not present to you with this one and all. Okay. What are the other things which you have to look for in the general examination apart from all these things?
Scoliosis, ma'am.
Good. Kyphoscoliosis you have to look for. Anything else? Pescavus. Because these two things can occur in Friedreich's ataxia. So we have to look for Pescavus and kyphoscoliosis. What is Pescavus? Increased curvature of the medial longitudinal arches, your Pescavus. You said about kyphoscoliosis, whether it is due to a neuromuscular problem or a bony problem, how to distinguish between somebody is having a kyphosis or somebody is having a scoliosis. So when they bend forward, if the kyphoscoliosis disappears, then it is due to neuromuscular etiology, and if it persists, then it is a bony problem. Okay. So do not forget about the Pescavus and the kyphoscoliosis in any child with whenever you are presenting with a chronic progressive ataxia. Because if these things are present, then it could be pointed towards your etiology, that is your Friedreich's ataxia. Okay, right, proceed. And about tendon xanthomos, as Ramakrishnan has pointed out. Okay, yes.
Higher CNS examination, higher mental functions. He's right-handed. Intelligence, he's able to write names and do simple addition. Is conscious, oriented to place, time, and person. Memory, recent memory is intact, but remote memory is affected. Speech, scanning speech, speaks single words slowly. Cranial nerve examination, first nerve couldn't be assessed. Mother says he smells food before eating. Second nerve, visual acuity 6/6 in both eyes. Color vision is normal. Bilateral pupils equal, measuring 3 millimeters in both eyes and equally reacting to both direct and indirect light reflex. Fundus, pale disc was observed in both the eyes. No retinitis pigmentosa or no cherry red spot.
Okay, why RP? Munish, why you have asked for RP? Why you have looked for RP, retinitis pigmentosa?
Gray matter disease, optic atrophy and pigmentosa scenes. Gray matter disease.
No, I don't think so. It's for example, you are thinking about the possibility of mitochondrial disorder, no? So it will help you. If the child had RP, then probably it is a clue for mitochondrial disorder. Why cherry red spot specifically?
Tay-Sachs.
That won't present with such a clinical picture, no? Tay-Sachs won't present with chronic progressive ataxia. Okay, go ahead.
You can escape by saying juvenile forms, juvenile GM1 like that. Okay, juvenile GM1 and all can have ataxia as a part of that, but not typical. Your infantile forms will not present with ataxia at all. Okay, so do not say what and all is not applicable to the case, then you will be landing up in difficulties. Pale disc, yes, you are supposed to see, of course, it is it is necessary for a MD postgraduate to look for whether the disc margins are clear or not, whether there is any pale disc or whether there is a temporal pallor is there or not. That much is sufficient. It will not be possible for us to comment upon the RP, cherry red spot. Of course, it is necessary that we have to look for a cherry red spot. Having mentioned about the cherry red spot, now tell me, how will you look for cherry red spot?
The surrounding disc, bright red.
Temporala, nasala. Where to look for? Where it will be present, my dear?
Temporal.
Yes, it will be present in the macular region. You have to go to disc diaptus temporal to your disc. There you will see the cherry red spot. Is it really red in color, my dear?
No, ma'am. The fovea.
How it will look like?
Grayish.
Grayish red areas.
It will be like a violet in color. Navapala color you will be able to see. That is your cherry red spot. Okay. What are the conditions in which you can see cherry red spot?
Tay-Sachs, Sandoz, GM1 gangliosidosis.
So GM2 gangliosidosis, that is Tay-Sachs and Sandoz. Second one is GM1 gangliosidosis. Third, Niemann-Pick. Fourth is your sialidosis. So these are the conditions which are commonly associated with cherry red spot. Proceed. Sarah has pointed out, as the PRC sir has pointed out, yes, RP can be seen in your refsums. Okay, so it can be in a mitochondrial disorder as well as in refsums disease, RP. Yes, but that is under optal opinion. We may not be able to find out. Of course, if we are that much well versed, we can see some brown spicules or in the periphery or in the retina. Yes. Proceed.
Third,
All the other
the
cranial
third,
nerves
fourth,
are
sixth,
normal, is it
normal.
not?
Yes, ma'am.
In ataxia, we are interested in seeing whether there is any ophthalmoparesis, what about the saccades, what about the pursuits, whether the saccades are broken. And one more important point is you have to tell us whether there is any oculomotor apraxia. That is much more important. Okay. In a child with suppose an ATM, there will be an oculomotor apraxia. So how will you look for an oculomotor apraxia? What is oculomotor apraxia?
Ma'am, in order when he doesn't move the eyes, he cannot move the eyes to see the side of the object. Ma'am, he'll turn the whole head.
Yes. Okay. That is oculomotor apraxia. So it is an important finding. It should be looked for in any child with chronic progressive ataxia. Any other condition which can have oculomotor apraxia? Any other ataxia having oculomotor apraxia? One is AT.
Ataxia telangiectasia.
Any other thing? There are another one condition called AOA, that is ataxia oculomotor apraxia type 1 and type 2. Okay. So in type 1 can occur in children, whereas in type 2 will occur in adults. So type 1 occurs in children. So we have to know about that also. AOA type 1. Okay. Right. Proceed. Other cranial nerves are normal?
Yes, ma'am. Eighth.
What about the eighth nerve?
Eighth nerve, he does not turn to sound, ma'am.
But he is a 17-year-old. You can't say that he doesn't turn to a sound and all. You have to tell us about Rini, Weber, ABC.
We tried doing the Rinis and Webers, ma'am, but like we could not tell
He did
him
not comprehend.
He did not, yes, ma'am. He could not.
But he was comprehending all the other things.
Yes, ma'am. He's
See,
not able to understand
out,
what
from
he
the history. Only we had only one or two, only one thing, whether there was no history of CSOM, something like that. Whereas here, and there was here we have to necessarily find out whether it is a conductive deafness or a sensory neural deafness. Unless otherwise you do these things, that would be difficult. Okay. Next, proceed.
Motor system. Bulk, there is no wasting, ma'am. Tone, upper limb, there's hypotonia in all four limbs. Power in the upper limb, the shoulders and elbow, the power is 4/5. In wrist, it is 5/5, pointing towards proximal weakness. Lower limb, hip and knee is 3/5 in both limbs, and ankle is 4/5. Reflexes, deep tendon reflexes, biceps, triceps, and supinator is 2+. Knee reflexes just seen, and ankle reflexes are absent.
Proceed.
Superficial reflexes, corneal, conjunctival, and parietal reflexes is present. Abdominal reflex and cremasteric reflexes are absent, and plantar is extensor.
Okay.
Sensory system, he's able to appreciate pain, he's able to appreciate touch and temperature. Position sense normal, vibration and joint sense could not be tested.
Why? What happened?
Sir, he's not able to understand like what we're trying to tell him, sir. Like,
Okay. That is very crucial, no? Vibration and joint position sense, especially he has got absent ankle jerk and all.
yes.
Okay.
Cerebral signs, pass pointing is present, intentional tremor present, scanning speech and bilaterally gaze evoked nystagmus is present, nose dysdiadokinesia, arm recoil test normal, truncal ataxia is present.
Okay.
Gait, broad-based gait with increased swaying side to side, spine normal, no signs of meningeal irritation.
Go back to the spinal motor system. My comments would be hypotonia. So there is a generalized hypotonia. Is it so?
Yes, ma'am.
Next line. So there is some amount of weakness in the lower limbs.
Yes, ma'am.
Because you have put it as 3/5 in both sides.
Yes,
you have to find out there is something called pyramidal weakness. Okay. Whether there is, you can't say that all the groups of muscles in all the joint is 3/5. You have to find out whether the hip flexors are more weaker, knee extensors are more weaker, and ankle dorsiflexors are more weaker. If it is so, then it is a pyramidal weakness. Okay. right? Or whether it is a proximal and distal, because you are saying that in the reflexes your ankle jerk is absent. So whether there is a distal weakness, that also you have to verify. Then about the DTR, I do not know whether all the other examiners accept this 1+2+. It is better that if you say whether it is present, brisk, or exaggerated, or it is absent. Okay, that would be the better terminologies. And because 1+ you mean to say whether you mean it is present or absent.
Two present, ma'am.
Present. 2+ தான் present.
Just eligible, ma'am. 1+ is just eligible.
That's why I am telling you whether you say whether it is present or absent. And whenever you say it is sluggish or absent, you have to immediately tell us that even after reinforcement, that word we expect from the students. You have to make it. You have to make the child to clench his teeth or hook his fingers and pull apart. You have to do that, and then only mention the reflexes are absent. Okay. Next thing. Next. Here again in sensory system examination, again as Ramakrishnan has pointed out, it is very much essential, since the reflexes in the lower limbs are absent, it is very much essential whether the large fibers, that is your JPS, is involved and vibration is involved or not. You have told joint senses could not be tested, but position sense normal. They usually go together. So JPS and vibration also, it is very much important. We do not expect a superficial sensory loss in this child. We expect only the deep sensation, namely JPS and vibration involvement in this particular child. So necessarily you have to test this again. Next. And about the cerebellar signs, whether a particular ataxia, that is finger nose coordination tested, whether it is normal or abnormal, you have to mention finger nose coordination present. Suppose finger nose, if you are not able to find out now, you have to complicate the procedure by doing finger coordination. Okay. There was when you are testing this, you could find out that there was a pause pointing intentional tremor accepted. And again, you said the titubation, that you have not mentioned in the cerebellar signs. From head to foot, you have to come, my dear. First, you have to say titubation, and then nystagmus, and then there is a horizontal nystagmus, bilateral gaze nystagmus present, and then a particular ataxia in the form of incoordination, finger nose incoordination present, pause pointing, intention tremor present. Then arm recoil, you are meaning rebound phenomena, I think. Rebound. Then dyslidokinesia. In the lower limbs, what about the lower limbs? Where is the heel knee coordination? You haven't tested. Yes. So in the lower limbs also, you have to test that. Then you said about truncal ataxia. Okay, good. So whether he is able to stand with his feet together?
No.
No means then it is on stance ataxia present. Next slide. Then Rambach, you have to say, could not be tested because he is not able to even stand with his eyes open, his feet together. In such a child, you cannot ask the child to close the eyes at all. So what you have to write is stance ataxia plus, then gait ataxia plus. He is walking with the broad-based gait with increased swaying to side, that is accepted. Then Rambach could not be tested. Spine normal, no signs of meningeal irritation. Good. Next. Fast.
Other system examination, cardiovascular system, this one has to hurt, no murmur. Respiratory system, bilateral iron present, no added sounds. Abdomen soft, no organomegaly.
So organomegaly is important in this particular child, so no organomegaly. Of course, we would like to expect that since you have included in the complaints itself, we had an bilateral pedal edema or breathlessness, etc. Whether the JVP is not elevated or not, and all you have not told us.
JVP is not elevated.
Okay. Next. He was not dyspneic, he was not tachypneic.
When he improved with treatment,
he doesn't have any tachycardia. Nothing.
No, ma'am, no dyspnea, tachycardia.
Okay. Probably because of he's on drugs for congestive failure, is it so?
Yes, ma'am. He was on Lasix infusion and he improved with treatment, ma'am. When we saw him, he was not.
Summarize and conclude.
17 years old adolescent boy, first born to non-consanguineous parents, who was developmentally normal till 9 years of age with chronic progressive ataxia, tremors, and dysarthria with loss of cognition, hearing impairment with past history of seizures. This suggests involvement of cortex and cerebellum. He has symmetric motor weakness with forelimb more than upper limb and proximal more than distal. He has extensor plantar suggestive of pyramidal tract involvement and absent ankle jerk. He has cardiac involvement and no organomegaly. Similar complaints is noted in the sibling. These findings are suggestive of neurodegenerative disorder involving both gray and white matter with predominantly gray matter involvement.
Maunik, just because there is cognitive impairment and the history of seizures is only once, I think cortical involvement may not be there. It could be due to cerebellar disease itself. So there is cerebellar disease itself can have cognitive impairment. So structure involved probably that may not be there. Okay, what are the structures involved? You just tell me.
So there is cerebellar involvement, sir. Yes,
both cerebellar, hemisphere, and Vermean involvement is there. Okay.
Both bilateral cerebellar involvement.
Okay.
Both cerebellar. Bilateral 8th cranial nerve involvement, sir.
Okay.
Probable pyramidal tract involvement is there, sir.
Okay.
Since there is absent ankle jerk with the weakness, it could be due to neural peripheral neuropathy also, sir.
Okay.
A cardiac involvement, sir. Probably cardiomyopathy, sir.
Okay. Pierre sir is asking regarding what is his apical impulse, cardiomegaly. Have you seen those things in your examination, especially the cardiac examination? Apical impulse, cardiomegaly.
There was no hepatomegaly, sir.
No, cardiomegaly.
Cardiomegaly. No cardiomegaly, sir.
No cardiomegaly. What was the apical impulse? Was it in a normal position only? No.
Normal position, sir. Not pushed down and out.
Okay. Secondary sexual characters.
It was normal, sir.
Okay. Okay.
Tanner staging 5.
Okay. I think you have to tell all those things also, especially cardiac, since he has presented with cardiac failure. You have to say about the apical impulse position, all those things, because that is all important. Because specific types of this cardiac involvement has some etiology. It will give you an etiological clue also.
Okay.
Madam. Okay, go ahead.
Yeah, as Ramakrishnan has pointed out, I will not accept this one involvement of the cortex, my dear, because some amount of cognitive disturbances can be explained in the cerebellar system itself, cerebellar involvement itself. And that was the seizure was a single unprovoked, and it was of a few seconds only. And whether it was unprovoked one also we do not know. And normally we do not take it as a seizure disorder, because by definition 2 or more unprovoked seizures only will be called as a seizure disorder. Okay, so I can we are not very much sure about that seizure also. So to be with this clinical findings and history, yes, pancerebellar involvement is sure, and both the cerebellar hemispheres as well as the midline cerebellar structures. And then you have an associated this much little bit of motor weakness, because he has a proximal weakness in the lower limbs, and definitely there is an associated peripheral neuropathy because of the absent reflexes. And since the plantar is extensor, and we have to bring in pyramidal tract involvement also. So these are the core clinical findings, and apart from that, there is an congestive cardiac failure he has presented to us with the failure. So these are the things we have, core things we have to give us a clue about the etiology. And already we have discussed that this is a neurodegenerative disorder. So now you have to tell me, and we have also pointed out those conditions that come under chronic progressive ataxia. So you have to fit in this clinical picture with any one of the etiological diagnosis, like whether it is a Frederick, whether it is a AT, whether it is a A-beta lipoproteinemia or a hyper-beta lipoproteinemia, whether it is a vitamin E dependent ataxia, or whether it is an ataxia oculomotor apraxia, like that. or whether it is an, these are all in children, progressive ataxias, chronic progressive ataxias are usually autosomal recessive. Only in adults you have autosomal dominant ataxia, namely spinocerebellar ataxias type 1, type 2, they are going in number, they are increasing in number. So scars. Whereas in children, it is only an autosomal recessive ataxia. So whether it fits in with AT, my dear? So I will not say that both gray matter and white matter, all those things. No. Here is an ataxia, predominant, this is a degenerative ataxia.
Yes,
so degenerative condition is accepted. It is predominantly involving the cerebellum. So degenerative ataxias are, since that's a family, all degenerative ataxias are inherited ataxias only. So inherited ataxia are otherwise called degenerative ataxia. That one only you have to discuss. Do not bring in white matter, gray matter, etc. here. Okay.
Have you checked the handwriting, Nonesh? Have you checked this handwriting?
Yes, sir. Yes, sir. He wrote his name, sir, but with difficulty only, sir.
Have you got a sample? You have to show the sample also if you have taken.
Sir,
what was it like? What was his handwriting like?
Like single letter, sir, but he wrote his name, sir, but with space in between. A single letter, sir, not joint handwriting. Very slowly he wrote, sir, with difficulty only.
Okay, was it micrographic? Like that I'm asking.
No, sir.
Okay.
Okay, now tell me whether it fits in with AT or not.
No, ma'am.
Sorry. Friedreich's ataxia. Friedreich's ataxia.
Yes.
Which is the commonest type of ataxia you come across in children? Chronic progressive, commonest ataxia, degenerative ataxia.
Friedreich's.
Friedreich. Second common is your AT. Okay. So now tell me whether it is fits in with Friedreich's ataxia or not.
Yes, ma'am. It fits in.
What are the points favoring a diagnosis of Friedreich? What are the points against?
Chronic progressive ataxia, ma'am. Then sensorineural hearing loss also supports it, ma'am. Cardiac involvement. Then sibling is also
which type of cardiac involvement? What is the type of cardiomyopathy?
Cardiomyopathy, ma'am.
Adaladan thambi endha enna type of cardiomyopathy? So should we give you a homework? What are all the neurological conditions which can be associated with the dilated cardiomyopathy, with the hypertrophic cardiomyopathy, like that? There is a tabular column in Nelson. Today you will go and read. Okay. Right. Here it is a hypertrophic cardiomyopathy. Okay. Friedreich's ataxia, hypertrophic. Next.
Sibling is also involved, ma'am. So probably autosomal recessive. That helps in. No scoliosis or no Pescavus, ma'am.
My dear, you have a progressive ataxia. That's number one. Number two.
Number two, sensorineural hearing loss.
For clinical findings, you have a pyramidal involvement as evidenced by your bilateral plantar extensor. You have another more important clinical finding, namely the peripheral neuropathy, by as evidenced by your absent
ankle jerk
in the lower limbs, yes, especially ankle jerk. Okay, these are the core findings which points towards you that it could be a Friedreich's ataxia. And you have an optic atrophy, pale disc is there, you have a hearing loss. So all these points are for your Friedreich's ataxia. And again, cardiac involvement. Okay. Now, next, whether it is an AT?
No, ma'am.
No. Yes, so in AT, which one comes first? A or T?
Ataxia telling.
Ataxia comes first varuma.
Ataxia comes in 3 years, ma'am.
As the name implies, A comes first, then only T. Okay. So before T comes, you can have ataxia. And there is no telangiectasia, there is no oculomotor apraxia, there are no history suggestive of recurrent respiratory tract infections. Hence, it is not AT. Next thing is whether it could be an A beta lipoproteinemia.
No, ma'am. No history of malabsorption, ma'am.
Okay. The clinical picture fits in with that? Apart
Yes,
from
ma'am.
this,
Yes, ma'am. Cerebellar involvement. Cerebellar
is there,
involvement.
peripheral neuropathy is there. So these points are to can vote for A beta, but there is no history suggestive of malabsorption. Fourth one, whether it is a vitamin E dependent ataxia associated with the vitamin E.
Yeah, ma'am. It will have same like Frederick's, ma'am, but
Very
cardiomyopathy and all will not be seen in vitamin E, ma'am.
Very good. So you can have a similar picture. So it is a, since as PRC sir has noted, it is a treatable ataxia. It's a metabolic ataxia, comes under degenerative again. So it has to be thought, it has to be borne in mind. Yes. Whether it is a AOA, there is no oculomotor
Oculomotor,
ataxia.
yes, ma'am. No
It is not a
oculomotor.
AOA.
Yes, ma'am.
Okay, right. And you are mentioning about something about mitochondrial. Is it a mitochondrial? Can it be a mitochondrial etiology?
Yes, ma'am. It can be mitochondrial, ma'am, because there is ataxia, there is peripheral neuropathy, there is cardiac cardiac involvement, peripheral.
Optic atrophy, hearing loss.
Yes, ma'am.
So,
Hearing
many
loss.
other systems also affect. So many multiple systems are affected. So it can be a, it can be due to mitochondrial etiology also. So
Yes,
there are some other ataxias, but we do not expect that much from you people. So if you say about, if you know about a Frederick, then ataxia telangiectasia, then vitamin E dependent ataxias, then we will be happy. Anything, Ramakrishna?
Nothing much, madam. I think we have covered everything, madam.
Other things are, there are something like Arsax, autosomal recessive ataxia of Chevrillonay sanguinea, then Marinesco-Sjogren syndrome. So many things are there. CoQ10 ataxia, again that will come under mitochondrial ataxias only. And suppose if you are thinking in terms of, they may ask you about the NARP, that is ataxia, RP and neuropathy, that is again mitochondrial ataxia. So that much we don't go into detail for an MD postgraduate. The first two things, yes, you must remember. There are some autosomal dominant ataxias, SCA, like type 7, 11, 13 and all, which can present in the childhood also. So autosomal dominant ataxias also can occur in children, rarely. And again, X-linked recessive ataxias are there. So all these things will come under this one, chronic progressive ataxia. Okay. Ramakrishnan, investigations and management.
How will you evaluate this child?
So I'll start with by investigating the child, sir. CBC and peripheral smear, sir. Peripheral smear to help us ruling out A beta lipoproteinemia, sir. Acanthocytes will be seen, sir. Then vitamin E, serum vitamin E levels, sir. Serum cholesterol levels. Serum cholesterol levels, sir. Immunoglobulin levels also, sir. In case of ataxia, serum immunoglobulin levels. Then neuroimaging with MRI, sir.
Acanthocytes, how much percentage should be there to say it is significant in the peripheral smear?
30%, sir.
It should be more than 20% to say it is clinically significant. Okay, then you said about lipid profile. Okay, immunoglobulin. Okay, then alpha feta protein also, but here we are not thinking of ataxia telangiectasia and all. So, okay, for Frederick's, if you are suspecting possibility of Frederick's before imaging, what other investigations biochemically you will do?
Gene, no, biochemical.
Not gene, yes, biochemically, not genetic testing. So what are the things that can be associated with in Frederick's? What are the things they can have apart from ataxia, systemic problems?
Biochemical.
Okay, they can have diabetes is common in these children or
diabetes
group. Okay, that you have to look for. Okay. Okay, go ahead.
For ECG and echo, sir.
Yes, definitely.
Look for cardiomyopathy. Hearing by Berra, sir.
Okay.
Then ocular examination, visual evoked potential, sir.
Why visual evoked potentials?
Uh,
It will not help you in any way, visual evoked potentials. No? See, probably ocular ophthalmologist opinion will help you. Visual evoked potentials may not help you. Okay, go ahead, go ahead.
So then mutation
How
analysis.
conduction study will you do? How it will help you?
Right. Mutation study, sir.
Nerve conduction study.
Nerve conduction study. In peripheral neuropathy, sir. To rule out peripheral neuropathy.
So in a child with ataxia, will you do a nerve conduction study? In what way it will help you?
To rule out peripheral neuropathy, sir.
Okay, probably okay. In Fredericks, they will have absent snaps because the one thing it is due to involvement of spinocerebellar tract and also due to involvement of the nerves proximal to the dorsal root ganglion. So they will have absent sensory nerve action potentials will be absent in all four limbs. That will give you a clue in diagnosing Friedreich's ataxia.
Yes, sir.
Okay. Go ahead.
So MRI, sir. And then genetic analysis for family, sir.
Genetic
Testing for family, sir.
first. Okay, family. Okay, first we have to confirm the diagnosis in him. No, then only probably family we have to check. Okay, what test will you order? For example, if you are suspecting Friedreich's ataxia, what test will you order?
Trinucleotide repeats, sir.
Yes. Yes, generally, for example, if you are going to do, for example, clinical exome sequencing, that these trinucleotide expansion disorders will not be covered in that. So you have to ask specifically to look for trinucleotide repeats. Okay. That is a special, that is a different test. It will not come under your regular test.
Yes.
Then
mitochondrial mutation analysis.
Okay, mitochondrial mutation analysis or mitochondrial gene sequencing we have to ask for. Okay. What are all the investigations we have done or you have done for this patient?
So MRI was done for this child, sir.
Yes, tell me, have you got the MRI picture or you are not? You don't have the picture? Have
No,
you got
sir, I don't have the. We've got only the report, sir.
So Sriram, probably you can ask him some questions or you can discuss. Okay, show us the report.
The MRI showed diffuse symmetrical T2 or flare hyperintensities involving bilateral cerebral hemispheres. Atrophy of corpus callosum noted. Bilateral basal ganglia was normal, sir. Spine and cerebellum was normal, sir.
Okay.
Impression was diffuse symmetrical hyperintensities involving bilateral cerebral hemispheres, sir.
Okay, cerebellum was normal, huh?
Normal, sir. Cerebellum was normal, sir.
Okay. 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 Go ahead. And how will you manage this child?
A multidisciplinary approach, sir.
Okay, multidisciplinary.
Speech therapy, occupational therapy, sir. Drugs for tremors, sir.
Mainly for cardiac failure, we have to manage, no? See, cardiac failure is one thing that is what made him come to the hospital. We have to find out what is the reason for his cardiac failure and manage it. That will make him better, first thing. Okay, second, okay, hearing loss, we have to take care. So, because that's one thing which is troubling him, apart from attacks, all those things, because if you make his communication better, then probably his language also might get better to a certain extent, but not at this stage. Okay, then for ataxia.
Yeah.
So nothing in particular, only probably based on the specific etiology. Sometimes you have drugs, but nothing in particular. Then what else do you have?
Physiotherapy, sir. Which is not B.
Okay. Madam, I think
Mitochondrial cocktail.
mitochondrial cocktail, I don't think it will be really useful for him. First of all, we really don't know whether it's a mitochondrial disorder or not. And of late, there are many papers which are saying that this mitochondrial cocktail is really not useful also. So probably that may not be really useful. There are some studies which says this idibinone given at the dosage of, that's very high dose, 900 milligram per day, it is useful, but I don't think that is really useful, all those things.
Vitamin E supplementation.
Yes, that is really important because that is a treatable one. Vitamin E supplementation we have to give. What is the dose we have to give?
50 to 100. 50 to 100.
Yes, per kg per day that we have to.
Can you tell me ataxia with peripheral neuropathy? What are all the differential diagnoses?
Friedreich's ataxia, ma'am. Mitochondrial disorders, ma'am.
A beta lipoproteinemia and then vitamin E dependent ataxia, AVED. Okay, ataxia plus hearing loss. These are the three core findings we are having. Okay, so we have to come to a conclusion, narrow down in between these two only. So ataxia plus hearing loss. Again, Friedreich's ataxia, mitochondrial ataxia, another one is Refsum disease. Okay, Refsum. What will in the general examination? What will you look for in a Refsum? That we have missed, I think.
Alopecia.
Refsum. No, not alopecia. It is ichthyosis. Okay, congenital ichthyosis we have to look for. Okay, so between these three only we have to find out. And another thing is in the investigations, and you have told about the biochemical investigations. Apart from the, why did you? What about the cholesterol levels? In what way it is going to help you in a child with ataxia? You have to do lipid profile, okay?
Yes,
in A beta lipoprotein, what are the beta lipoproteins? You said about A beta or hypobeta. What are the lipoproteins which come under this category? Beta lipoproteins?
Apolipoprotein, ma'am.
LDL and VLDL, doctor. So those things will be low. Okay. And again, you have mentioned about CTX also. Is it not?
Yes, ma'am.
In CTX, the cholesterol levels will be low, but 70 hydrocholesterol or otherwise called cholesterol levels will be high. Okay. One more thing is the serum albumin will be low in AOA type 1. So these are said to be the biomarkers for this attack, the conditions with the ataxia. Okay, that is number one. And about everybody will be asking about AT only. So for suppose you are suspecting an AT or if the child has an telangiectasia, what are the things you will look for first? Nobody is going to blame you if you do not know other things. But AT as a pediatrician, we must know. Yes.
Telangiectasia, ma'am. Oculomotor apraxia.
Investigations.
Immunoglobulins, ma'am.
Very good. In the CBC itself, we have to have a, let me say, CBC itself, we let us have a baseline and the peripheral smear because these children are prone for
recurrent in sinopulmonary infections, ma'am. So total.
Number one.
Leukemia.
Another one prone for, yes. You have to mention the word lymphoreticular malignancies. Okay. Leukemia, lymphomas also. So lymphoreticular malignancies, recurrent sinopulmonary infection. So baseline CBC, peripheral smear. Next.
Serum immunoglobulin.
Serum alpha fetoprotein. Immunoglobulin profile in which, what are the immunoglobulins which will be low in AT, which will be high in AT?
IgA is low.
IgA is low. IgA is low, E is low, G2 is low, G4 is low. Other things will be elevated. Okay. And you can have a X-ray test with the sinuses also. Another thing is this disorder is a defective, this is associated, it's a disorder of defective DNA repair. So you cannot take CT at all. It is more prone for radiation, is it not? So
Yes,
they can undergo only an MRI. These are the things you have to mention to us. Okay. So this will cover the entire investigations. Of course, depending upon the condition, other things are optical opinion, ENT regarding hearing test, ABER. Okay. As Ramakrishnan pointed out, NCS. This will complete. And in MRI, what are the conditions under this chronic progressive? Which are the conditions are associated with cerebellar atrophy, in which cerebellum will be normal? That will finish the discussion.
Frederick's cerebellar atrophy. Normal. Cerebellum normal, ma'am. In Frederick's, you can. Frederick's cerebellum is normal, ma'am.
See, in AT, cerebellar atrophy. Without cerebellar atrophy, you cannot diagnose AT at all. Similarly, AOA, there will be cerebellar atrophy. In all the other things like Frederick's ataxia, A beta lipoproteinemia, vitamin E dependent, in all those things, the cerebellum will be normal. Okay, fine. And apart from that, then you have the genetic diagnosis, etc. And as Sarah has pointed out, PRC has pointed out, for Repsum, it is protein, it is a diet modification will be helpful. Repsum is due to
Phytanic acid oxidase.
So VLFA assay also will be useful in diagnosing Repsum. Okay. And again, recently people are telling plasmapheresis will be useful in Repsum also. Okay. Right. So our neuroradiologist can throw some light about this.
Am I audible? Shall I start sharing my screen?
Yes, Sridham.
Yes. Is my slides, is my screen visible?
Yes.
Yes, visible.
First and foremost, I think I would thank IAP for giving me this opportunity. I am the consultant neuroradiologist practicing in KMCH Coimbatore. This is a very difficult case, as often is the case with most of the pediatric cases. From the way I practice generally, I look at what is my clinician looking for. And I try to search the relevant literature whenever I am presented with a difficult case. So the way I see this from the discussions for the last hour and a half, I think we are looking at an overlap between an inborn error of metabolism or a neurodegeneration presenting with slowly progressive ataxias, which means a combination of movement disorders. So then I look at any kind of recent articles that kind of gives me an insight into how radiology might add value to the clinical discussion. And I must say that it's been long since I've attended such a high quality clinical discussion, which intrigues me, a little bit of scares me as well. I've been a MBBS resident and I have gone to ICH. So I know it's a scary space, and I would first congratulate the resident for holding up to Madam first. You know, it's not easy when you know you're talking to probably the experts in the field. So I would be very cautious in approaching. I will just call up my clinician and ask them, sir, can you please tell me what do you look for in this imaging? How may I help with? So then I go through relevant literature, and then I came across this study which provided an overview of the literature between movement disorders and IAM. And believe it or not, there are 231 or so disorders that have been diagnosed. And how does imaging help? Not always. You can see that quite a few of them can be normal, and some of them can be with atrophy, with heterotopias or structural abnormalities, some of them with atrophy in general, or with respect to cerebellum, as Ma'am pointed out, especially in the onset of cerebellar ataxias. And there is a fallacy there. How do we quantify or look at cerebellar atrophy? What defines atrophy? Because what looks like atrophy to one eye might not look like an atrophy to the other eye. So I prefer having certain criteria. They say the folia, if it measures more than 2 millimeters, is a quantitative marker, but that sometimes may not be always be helpful. Let's say we have a 2.2 millimeter. Would we say that is abnormal? Do we have 1.8 so it becomes normal? So I also, in my practice, look at, am I seeing more CSF space than is required for that age? And is it restricted to the infratentorial brain? Especially we get many of these early onset normal appearing brains, which will have very minimal superior cerebellar atrophy. So I would look at those regions very carefully, because those are blind spots I have seen Some of the scanned reports don't mention it. I don't think all the images are covered in the films. So if you happen to have a CD, I would say one useful hint for looking for early cerebellar atrophy is to look at the superior cerebellum and the vermis, trying to measure the folia, the CSF space between the two cerebellar cortex. And if it's more than 2 mm, it's probably definitely atrophied. Or if it looks just more prominent than usual in a corresponding scan of a same age group. We do scans 10, 15 in a day. So it's easy if I can just compare a 2-year-old child with a 2-year-old child. You can have thinning of the corpus callosum, callosal abnormalities, myelination abnormalities, leukodystrophies, which is what we are probably looking at in this case because the report showed a diffuse white matter abnormality. And they can be either restricted to the white or the gray matter. And you can see the differential varies depending on involvement of white versus gray and what in gray is involved. So the approach would be, once I see a diffuse white matter abnormality, the next approach would be, am I looking at a delayed myelination, hypomyelination, a dysmyelination, or a demyelination? I would just talk briefly about that. These are the examples that I came across in the article. You could have a short chain enamel hydratase deficiency, which bilateral globus abnormalities with a small cavitation. You can have a type 3 Gauchers with hydrocephalus and volume loss in the white matter. You can have a GLUT1, which is a glutaric aciduria, classical basal ganglia abnormalities. You can have other periventricular white matter hyperintensities. Apparently, it's seen in rhizomelic variant of chondrodysplasia punctata. You can have the L2 hydroxyglutaric acidurias with subcortical involvement, more diffuse white matter, and more specifically dentate involvement. You can have thinning of the corpus callosum or calcification like in an Aicardi Gaucher's or a homocystinemia. So, but this is radiology. I would say that it's easier for the clinician to just keep excluding the examples I throw out to the clinician. Sir or ma'am, can it be this? No, doesn't match. Can it be this? No, doesn't match. So it's much more easier. Use of advanced imaging like a spectroscopy to look for a mitochondrial pathology since there is cerebellar involvement. You'll have to understand certain caveats. Where are we putting the spectroscopy? Any gliotic area or an infarct that in a basal ganglia might often show a lactate peak. If the adjacent normal appearing deep gray matter is going to show a doublet peak, and it depends on what spectroscopy you do. As we can see here, you've got a number here. Always look for this number that denotes the TE or the time to echo. And this is an intermediate TE spectroscopy. When you see an intermediate TE spectroscopy showing an inverted doublet peak, that's classical for a lactate. It everts or becomes erect if you do the same on a different TE. If you reduce the TE to, let's say, 20 or 30, that's a short TE spectroscopy, and then it will be erect or upright. If you do a long TE again, is anything beyond those 140s and 150s, you can have a TE at 240 or whatnot. The numbers variable, but somewhere around this 130 to 140 is your intermediate TE. And you can sometimes have those isolated creatine deficiencies, which can only be detected on a spectroscopy. So I would say a complete imaging for an inborn error would be to have a plain imaging, would be to have a spectroscopy, decide based on these two whether you want to go for a contrast scan or not. And a spine screening is absolutely required if there is cerebellar involvement. These are the clinical helpful hints that I take the same article, which I use for my differentials when I give a report. So this is the basis. These are 4 slides for this case. And these were prepared just as I was going through the discussion. But in general, I think if you want to have an approach towards white matter diseases, there are a couple of things the residents should be aware of. What is hypo? What is dysmyelination? What's demyelination? So a delayed myelination is just a delay in myelination, which means at 6 months, the child's myelin is not the same as it should have been using an atlas. So then you have an atlas with you, you can compare, or you can have a table that is stuck to your desk. And you have to do a repeat imaging after 6 months and see whether there is progression or not. If there is no progression, then it might be a permanent deficiency called an hypomyelination. The criteria being 2 scans, 6 months apart, preferably with the second scan done after the child is 2 years of age, is ideal to diagnose a case of hypomyelination. Then we come to dysmyelination, where there is abnormal myelin deposition, in which there are recurrent attacks of metabolic decompensation, causing what is called an intramyelinic edema. And then you've got normal myelin which gets destroyed, that's called a demyelination. So if you want to know leukodystrophies in detail, And to be updated about it, it's all genetic nowadays, and it's changed from the earlier classifications. You have the hypomyelinating varieties, the myelination defects, the vacuolization defects. You have the astrocytopathies. You have the leukoaxonopathies. You have the microgliopathies and leukovasculopathies. Again, quite exhaustive. I won't go into the details of each and one. But on an imaging, how can you approach it? You first differentiate hypo from a dysmyelination. A dysmyelination will be more confluent, severe white matter changes. Hypomyelination is mild white matter. On T1, it appears to be almost normal or slightly abnormal. So that is the helpful hint. And once you go into a white matter disease, then you see whether it's a frontal involvement, it's a periventricular involvement, a diffuse involvement, if it's going to be a posterior parieto-occipital involvement or a subcortical involvement. You've got posterior fossa abnormalities specifically, like in this particular patient, where it was more of cerebellar involvement clinically, and then we have the differentials based on those. Multifocals are usually acquired, as you can see, of the ADAMS, the torch, and the other stuff. Some of them can still be hereditary or an inborn error. Then you've got the peripheral neuropathies and those associated with hypomyelination, and the ones without peripheral nervous system involvement. So this is in essence the approach, hypo or not. Look at that, then decide whether it's diffuse white matter or multifocal white matter. Based on that, and go on to third, what is the pattern of involvement? This is the kind of chart that one should use for myelination, and these are the age at which the myelination happens. I will share this later on for want of time. I just want to show you on image how it looks. A normal myelination proceeds in a temporal fashion in a stepwise manner. It goes from central to peripheral, it goes from caudal to rostral, and it goes from posterior to anterior. That is the order in which the myelination proceeds. On a T1, it will start appearing brighter. How do you identify T1? It's an anatomical sequence. Gray is gray, white is white, CSF is dark. And it is the first sequence to show myelination. Unmyelinated white matters will appear hypointense on T1. As the myelination progresses, it becomes hyperintense or bright. So the early myelinated structures, the plic, the ventrolateral thalamus, then we have the corpus callosum, then going on to the parieto-occipital and then the front. The subcortical white matters are myelinated in the end. We should not confuse a periventricular flaring or a terminal zones with a periventricular leukomalacia. There will be volume loss, irregularity in the latter, which is pathological. Simple VR space and posterior periventricular white matter changes may be physiological. So this is, in essence, the various structures. I mean, I have a few case images to show, just to wind up. Step 1, hypomyelination or not. What are we looking for in hypomyelination? Once we understand or identify hypomyelination, which means you've got 2 scans, 6 months apart, with the second scan showing more than 2 years of age, showing diffuse T1 hyperintensity, which means it looks myelinated on T1, but a mild diffuse hyperintensity on T2 or flare, then started looking for other patterns. Involvement of the globus in fucosidosis, involvement of the basal ganglia and gangliosidosis, involvement of subcortical structures in congenital cataract, and then you got the cerebellar involvement, which is very typical in 4H. You will of course have the clinical clues like an hypogonadotrophic hypogonadism, hypodentia and this. Diffuse involvement with the tigroid appearance, the Pelizaeus Merzbacher's, with involvement of the pons is the PMLD or the Pelizaeus-Merzbacher-like disease. These are some of the specific entities. And then if you finish and excluded hypomyelination, and you think this could be because hypomyelination itself can be variable. It can be mild to severe. So not always you will have the same rule being applied. Sometimes I will be able to tell, even if in the severe case, it is going to be hypomyelination based on other things, the other areas that is involved with the clinical red flags. So that is one thing to be kept in mind. Specific examples, diffuse hypomyelination PMD, involvement of the pons PMLD, severe cerebellar involvement 4H, involvement of the basal ganglia and the globus fucosidosis, basal ganglionic involvement along with white matter hypomyelination in GM2 gangliosidosis, the congenital cataract with diffuse white matter abnormalities, then the subcortical and other diffuse in Salas. This is one condition which will also have an increased NAA peak, just like a Kahneman. Then you go on to dysmyelination or demyelination. The ones that are demyelinating, which is a normal myelin and then destroyed, are often multifocal, often acquired, post-infectious, or it can be other acquired causes. Some of them can also be inherited, versus dysmyelination, which is more diffuse and confused. And the genetic disorders that can present with the multifocal pattern, the cadasils, the LBSLs, which is brainstem and cord involvement, MPS and galactosemias, and acquired disorders like a toxic involvement. And some of the examples of them are given here. So I'll just round off with classical examples: frontal involvement, leukodystrophy, dysmyelination, Alexander. Remember, adreno is more posterior, but you have a frontal variant of adreno. Metachromatic is more diffuse, but can be frontal involvement. HDLS has now been renamed as CSF1R related leukodystrophies. It will have something called a stepwise calcification on your CT. Pareto-occipital, adreno, Krabbe's. Sometimes peroxisomal. Peroxisomal will also have migration anomalies coexist. Diffuse cerebral is the Vandernapp or the megalencephalic leukoencephalopathy with cyst. Vanishing white matter is again diffuse. And then you've got subcortical involvement as seen in Kahneman's urea cycle. You have scalloping involvements. And then the L2 hydroxys, the propionic acidemias, Kearns-Sayre's. And periventricular, again, there is a lot of these things, examples. Certain other specific things, yeah. See, I think cerebrotendinous xanthomatosis, CTX was discussed. Peridentate involvement with a tendon xanthoma, that is classic. So this is your tendon xanthoma that happens in your CTX. Coming to other things, yeah. The last part of it, any additional special features should be looked for with importance. Any cyst, any rarefaction, enlarged PR spaces, enhancement, calcification, microbleeds, cord involvement, and what happens over time. I think I would stop here because we need a couple of minutes to summarize. I would send across some of the references later for those interested. Thank you so much.
Thanks, Sriram. That is a very wonderful presentation. Thank you.
And I must acknowledge Dr. Kannan's contribution. He was a pediatric neuroradiologist and he gave most of the slides at the last moment. Thank you so much. Yeah.
Nice, Dr. Sriram. Actually, you have to give us a lecture on this, how to read this, all these MRIs.
I'm happy to help, ma'am, but I feel overawed. I feel scared of addressing you. I mean, it brings back memories.
No, my dear, there's a lot to read. That's a lot to learn, in fact.
I think that's inspiring coming from your words. I mean, from the discussion for the last hour and a half, I think I would have shitted in my pants if I was a resident. I would seriously be scared of having to present a case to some of the masters in the field. And I feel it's privileged having a clinical discussion that helps us grow more, because these discussions help us and tell us what exactly, we need to tell our clinicians. I don't have to tell such an expert what to look for. I need to ask them, what are you looking for? I think the question depends. And that's what I learned from this.
Yeah, actually, we should have had that MRI. In fact, we were so far we are discussing about predominantly cerebellar involvement. Now we have an MRI which is involving bilateral symmetrical involvement of T2 and flare hyperintensities in the both the cerebral hemispheres and the cerebellum. It's difficult. It's really we have to appreciate the postgraduates for such a nice history and a clinical presentation. So if you say Frederick's ataxia, then we are more satisfied. And if you just tell us all the 4 ataxias or the conditions coming under chronic progressive ataxia, and whether this is what are the points for Frederick or against Frederick, if you say that, we will be happy, my dear Dr. Gautam and Dr. Maunish.
Yes, ma'am. They presented really well, madam. And
yeah,
this
is a very difficult case. This is not a case for MDs. However, they have pulled it very nicely.
Thank you, ma'am.
Congrats, my
Thank
dear.
you, madam.
Thank you, ma'am.
Thank you very much, ma'am. This is Dr. Murugan, AAA or AFD. See, Dr. Our secretary has to leave due to a personal reason. So it was a wonderful discussion we have had today. I think, as always, madam made clinical examination so simple and so easy. And before we proceed further, can I request any comments from our judges, Dr. Srinivasan and the rest of them, please. Sir, please unmute, sir.
சரி, என்ன சொல்லி பாடுவேன், என்ன சொல்லி கூறுவேன், எங்களுக்கு இவ்வளவு வழங்கி தந்த factual informations. There is nothing, no words to express my thanks. I am always learning from Lima Pauline, as Sriram has mentioned. And Sriram, thank you very much for your excellent article and this thing, so much to learn. So thank you, and I congratulate the students who presented well, and also the discussions that brought so much of insight into the ataxias. Thank you so much.
Thank you, sir. Any comments from Ramesh, sir?
Sir, thank you. Today's discussion was at the very highest order, I should say, because lots of things were asked, lot of things were discussed, lot of neurology taught, and it was like Professor Lima was at her excellence, and it was like a verbal diary. I know she was running like a Rajdhani Express.
She has always been excellent, at her best. Whenever I have listened, she has been at her best. I'm sure all the students will acknowledge that.
Yeah, unless the students come well prepared, it will be very difficult to follow, because a lot of things are taught, and especially today's presenters are at their best, because they did a wonderful job, because the history taking was nice editing of the history, clinical findings were well explained. And the today's, I should say, the discussion was like a DM neurology discussion, but they stood up to all the assaults. And I request the students to learn the definition, medical terminologies, exactly what is given in the textbook. So then it will be easier to fit in with the clinical picture with the accurate definition. And today, another comment I always pass is, the other two presenters should not be just listeners. They should also take an active part in answering the questions, and they should share the questions so that it gives a classroom look, and 2-3 people discuss. So though they are knowledgeable, they are just prompting to the presenter, but they should actively take part also. About the diagnosis, in the examination, it is only a clinical examination. You are having access only to the clinical examination, so you need not worry about the final diagnosis or what the reports say. With the available findings on that day of the examination, the available history, what are the possibilities, like Professor Madam said, you can say 4 or 5 diagnoses also, and ultimately it may be totally wrong also. We don't have to worry about that.
Thank you, sir.
Okay, thank you, sir.
Anything else, sir? Anything else to comment, sir? Sorry.
Oh, that's all. Thank you.
Thank you, sir. PRC, sir.
Thank you. So once again, it's a wonderful experience listening to Dr. Lima and Dr. Ramakrishnan. So it's really, we were in the classroom listening to them as teachers. So, and the students did very, very well. So I should really appreciate the way they presented. The presenter was Gautam, isn't it? Maunish. It is not Dr. Maunish.
Maunish, sir.
Oh, Maunish was the presenter. Okay, thank you. Maunish, Gautam, and
Harita, sir.
Harita, thank you. So all of you were there, very nice. And the questions, I really appreciate the history. It was very well presented, and the flow was very good. Nicely, all the relevant negative points only. We did not go overboard with the negative points. That is one thing to be appreciated. And of course, most of the things, because with about 2 or 3 decades of experience, we cannot match the neurologists. So definitely you answered as expected for a good MD postgraduate. All the relevant things were actually answered. I'd just like to say some of these patients who we are not able to give much in the form of cure, always talk about something like a counseling the parents and other things, family support. You just mentioned it, include it in your final treatment. Okay, this family has got 2 children. Anyway, Dr. Ramakrishnan is the one who has to do this most difficult job of counseling the parents and how best to take care of these 2 children who are already affected, another child with some life-threatening problem of a cardiomyopathy. So he's the one who has to do it, but you can include it during your treatment part of it. So other than supportive treatment generally, you can also tell them about the counseling part. So with this, I once again thank IAP TNSC and all the moderators and the teachers for today and the presenters. Thank you so much.
Thank you, sir. Thank you, sir. Amma, ma'am.
Yeah, and I have nothing much to add except to congratulate. I can't say congratulate. Lima was at her, what shall I say, eloquent best. Lima, I've missed all your sessions being away from ICH.
Madam, thank you, madam.
Yeah, I mean, you're the same passion. You're speaking and teaching the students, and I think I don't know whether
She still remains very young. She looks like
she does.
What I have seen her 25 years back.
Yes, and Maunish, I joined a little late, so I don't know which institution you're from. You're from which college?
Kuppusamy Naidu Hospital.
Okay, you have done a fantastic job, and I too felt that the people at the periphery, I mean, behind you, they didn't answer much. I could see her telling you some things, but you should also join in the, you can also give him a break. That's the only thing. And MRI pictures, please show us in your case pictures whenever you present, okay? Because it will add strength to your presentation. And Dr. Ramakrishnan, of course, was very supportive. And Dr. Sriram, we really enjoyed your you're a pediatric neuroradiologist, or do you need to know so much of neuroradiology even for a normal radiologist? I don't know.
No, I'm a neuroradiologist. That's my DM from demands.
Okay, because there's so much in degenerative disorder. I used to compulsorily be our long case in MD, and we used to, what shall I say, mug up the differential diagnosis, because if there are these three clinical findings, what is a possibility? We had no other choice but to know and we were pretty good at that time. Now we have forgotten everything over the past so many years, and MRI now has come as a big blessing for us to find out, But in those days, there was no escape. We had to know it, and I don't know whether they're still having those things as a long case. But whatever said and done, make use of this opportunity, because you will not going to see this again for the rest of your life unless you become a neurologist, pediatric neurologist. So you please keep, mugging up the symptoms, which is necessary for the differential diagnosis. At least 2 you should know, okay, for each condition. Okay. So good luck to the presenters. You've done a good job. Thank you, IAP TNSC, and you're giving us an opportunity to sit through these sessions, something which we wouldn't have done otherwise. So we are also learning in the bargain. Thank you all. And
thank you, ma'am. Thank you very much. I think the pleasure is all ours, actually, to have such a galaxy of learned people. I mean, it's real stalwarts of pediatrics contributing for the discussion. As everyone said, I mean, it was a wonderful discussion. And Lima madam at her very best. I was just trying to even catch up with the differential diagnosis, and I was really struggling, actually. Even though I do have a bit of interest in neurology, I just couldn't actually. Thank you very much, ma'am. And I think, as everybody said, the students did a fantastic job. So is Dr. Ramakrishnan, and of course Dr. Sriram. I mean, he thought he was making it simple, but let me assure you, it was definitely not simple. So thank you very much. I think it was a wonderful evening we had, and hope to meet you again in future. Thank you very much, and good night.
Thank you, IAP TNSC. Thank you.
Thank you, ma'am.
Thank you.
Thank you, ma'am.
Thank you. Thank you, Ramakrishnan, and thank you, Sriram.
Thank you, madam.
And good luck, my dear students.
Thank you, ma'am.
Thanks for the nice presentation, Monish.
Thank you, sir.
Thanks, everyone.
Thank you, sir. Bye, sir.
Thank you.
Dear
Thank you.
sir.
Thank you. Bye.
Good night,
Bye.
sir. Good night, everyone. Thank you.
Bye.